now we have the IVUS technology. We've talked a little bit about sizing and the importance of sizing in the peripheral space. How do you go about this for Shockwave? Because I think intravascular lithotripsy is a unique device that requires some real thought into sizing.
I mean, ultimately, I kind of size everything the way I size Shockwave. So I'm a big believer in low pressure angioplasty, right? And Shockwave is a technology that allows me to deliver low pressure angioplasty, and in addition to that, intravascular lithotripsy technology. So it's 2-in-1. So typically, whenever I pick a balloon, whether it's a Shockwave balloon or a conventional PTA balloon, I'm going to oversize slightly. And if I have the information based upon IVUS, I get to do that a little bit more accurately, and I'm not sort of just guesstimating what I'm doing. But generally, you know, we use 1.1 or slightly larger than the reference vessel diameter to select our Shockwave balloons. The same thing I do with my conventional balloons. And I feel very comfortable because I'm taking the balloon to 2, maybe 4 atmospheres. So the risk of perforating or causing a barotraumatic dissection, I think, is really, really low. So I feel very comfortable oversizing.
That's a great comment. And if you look at all the data, and again, the unique thing about Shockwave and intravascular lithotripsy is there's a lot of data in the periphery. We talk a lot about lacking data for other devices. This is one area where we're a little bit data rich. And I think when you look at that data, we know that patency, as was seen in the PAD-2 randomized trial, is improved if you oversize or optimally size the device compared to if you use it at an undersized or a 1-to-1. And then also if you look at predictors of patency or lesion improvement, that always oversizing is a strong predictor. But at the same time, when you look at the complication or adverse event data, you don't see a lot of dissections, right? Mm-hmm. So we know, like your comment is, you have a low pressure inflation, so you're preventing that barotrauma of overextending with a balloon angioplasty, but you're still getting a really effective treatment and treatment resolution. And I think that pans out in all the data that we've seen.
I think no one ever feels good when they take a balloon to 10 or 12 atmospheres in a tibial or a distal SFA. You know, I think when you're taking balloons to burst, it never feels good. I don't know if you feel the same way.
Oh, absolutely. I mean, I think you're doing something that you're not comfortable about because you didn't make a great decision to start. And that's how I think about it. Yeah. You know, either you're like, I probably should have vessel prepped better and I'm trying to get out of it right now. Mm-hmm. Or I probably should have sized better and I'm trying to get out of it right now. And so we all do it with like, we're going to get away with this. Then you take the angiogram.
They're like looking up and down and deflator.
I always think, you know, it's important just to be thoughtful up front instead of reactive to a complication. And, you know, and you know, looking at some of the data, even at 2 to 4 ATs with an IVL appropriately sized 1.1 to 1 or greater, you're getting still 50 times the atmospheric delivery of pressure or equivalent of pressure with that energy transfer. So it's not like you're not treating the vessel, you're just not challenging the vessel with an overinflated device.
Yeah, you're letting the lithotripsy do the work.
Exactly, yeah. So, you know, a big thing that also comes up if you're not a big IVUS user is how do you size? You know, what's the right reference vessel or reference device to size off of? Some people will size off their sheath, especially if they're doing more large bore work. Some people will size off pre-diagnostic imaging like a CT scan. Again, I'm biased, but I size off of IVUS. Any thoughts in terms of where you're looking for a healthy reference vessel for sizing?
Yeah, I mean, I think when you have experience, you get a pretty good sense of what size different blood vessels are in different locations. You know, some people use the actual sheath size in relation to the vessel on an angiogram and sort of extrapolate based upon that. But I think for someone who uses IVUS frequently, like myself, like yourself, you know, you have a tool that allows you to be very accurate and precise. And I think that we should aim to be as scientific and as accurate when we're taking care of patients. So if you've got a tool that's going to help you size accurately, you should use it.
I appreciate that comment. And again, what I typically do if you are going to use IVUS, but even if you're not, it's really important to find a healthy reference vessel to size against. Typically, you can look distal or proximal, but you're going to have a slightly larger vessel proximal. And then even when you're making measurements, you know, if you look on even IVUS, some people trace lumen to lumen. Traditionally, even in the coronary space, we trace the EEM or the external elastic membrane to EEM. So if you're not comfortable doing that, even taking the lumen diameter and rounding up or going up a 0.5 millimeter is really an effective way to getting a size or diameter for the vessel to treat off of. So yeah, I find the sheath comparison could be a little challenging. And, But, I think everybody has to be comfortable with how they do it. But I would encourage new and even more advanced users to really find that reference vessel on IVUS ideally, but if not an IVUS, on angio, and then always just add that factor of rounding up. And I think that's a theme of us today about going big. I think we also have the unique part of IVL in these profile of these devices being able to address very different vessel sizes. So we have the catheters that can go below the knee. We have the balloon catheters that can treat the femoral popliteal, the M4s, and then the L6s now that are able to treat the iliac disease. And so, it's wish we could always be so clean. We're only in one arterial segment, but we're typically crossing over and we have multi-level disease. How are you thinking about that when you have vessel tapering, or you're going from, again, like from a popliteal into a TP trunk, and, now you're crossing around two different diameters?
Yeah, I think it just goes back to the fundamental mechanism of the angioplasty mechanism of shockwave. It's that low pressure balloon angioplasty. So I'm very quick to grab an M5 plus, even if I'm treating tibial disease, because I like that extended catheter length. I like the length of the shockwave device in comparison to the 4 centimeter S4. So I like the idea of having a long treatment area. And let's say I'm treating from a proximal AT or TP trunk or PT into the distal popliteal artery. I can use a 4 millimeter shockwave balloon there very comfortably, because I know that 4 atmospheres or 2 atmospheres of that inflation isn't going to do anything catastrophic in any way, shape, or form. Sometimes I'll err on really oversizing my shockwave balloons too if I know I need to treat like a P1, P2, P3, and a proximal tibial, because when you start opening up multiple shockwave balloons, and administrators might be me asking questions or looking at you, at least where I am, for the cost of the case. But I think it's incredibly safe, and the profile of devices we have available to us has really opened doors to locations that we historically haven't been able to treat, or as a vascular surgeon, areas that we didn't really want to treat percutaneously. So the L6 and the M5 Plus and the common femoral has been a great new tool in my toolbox to deliver care to certain patients that probably wouldn't do well with an open surgical intervention.
Yes, wonderful pros there. And I think one thing you mentioned at the beginning of that was about the length of the balloon catheter. And if a lot of times we have lesions that are close together at healthy or less disease areas in between. What are your thoughts about inflating and shocking in that middle healthy reference area? I mean, is that ever a concern to you?
No, it hasn't been. And, I've never really given that much thought, because, with conventional balloons or other specialty balloons, I wouldn't hesitate to treat that location. Like, I'm a big believer in prolonged balloon angioplasty with longer balloons, treating from healthy to healthy, and doing it as expeditiously as possible. So I haven't encountered any issues treating healthy segments or intervening segments between islands of disease. But I've never really encountered any issues with that sort of, using conventional therapies.
Yeah, I share your opinion completely. I think having that longer length is really helpful. I'm not scared of going a little bit larger in that, TP trunk or proximal AT if I'm able to cover back into the other disease part, if it's in the popliteal, or same thing, extending an iliac down into a femoral. And again, I agree with you. I think that shocking a normal vessel with at 2 to 4 ATs is, I'm not concerned that I'm going to cause any additional trauma there.
It's benign.
Yeah, and then when I use a lot of drug-coated technology, and I'll take long DCBs and cover even moderate disease with it, just hoping that I can get as much benefit for the patient, potentially halt any plaque progression with that therapy. I think of it the same way as vessel prep with the IVL.
I mean, at the end of the day, this is a progressive disease process. Even after we deliver, the best care we can deliver, these patients are our patients for forever. We follow them very closely. And, you follow them closely because you know what's going to happen, even with best medical therapy. You just got to try to slow or mitigate the issues that come downstream from peripheral arterial disease.
Great comment, yeah. So, I'm going to summarize this first section as size appropriately. IVUS is a great tool. It's a great tool for understanding calcific burden. It's a great tool for measuring vessel diameter, for making sure you understand what a healthy reference vessel is. And then don't be scared to oversize. We got a low pressure device. Always round up, go to the 1.1 or even larger. The dissection rate is low. This is meant to be really a comfortable low pressure device that can still be effective in delivering therapy. And if you want to really take advantage of this technology, these are key pearls to really using intravascular lithotripsy.
Yeah, absolutely.